Okay, hi बच्चों, good evening. So let me know if you can hear me. Audible? Great. Thank you, Abhinandan, for telling me that I'm audible. So yesterday we were doing placenta previa and I had to do management of placenta previa and we were talking on the live chat that we need to discuss on your strategy also कि अब कैसे how you people are moving ahead. Some of you are getting anxious, some of you are having that stress ki ab exam is coming closer and closer. So we will talk all about it towards the end of the session. First of all, let's finish our topic, which is very important, and that is management of placenta previa. Now, when we talk about management of placenta previa, प्लासेंटा प्रेविया के ऊपर दो टाइप के क्वेश्चंस आ सकते हैं राइट मैनेजमेंट के ऊपर दे कैन बी टू काइंड्स ऑफ क्वेश्चंस and these questions can be in the form of case scenarios. So number one case scenario is they give you a situation that a pregnant patient obviously, has presented to you with bleeding per vagina at more than equal to 28 weeks and they ask you what is the next step. कुछ नहीं दिया, right? They are not telling you whether it is a case of placenta previa or whether it is a case of abruptio, and simply you are getting a question that there is a pregnant female who's come to you with if you were there in an emergency, a patient who has bleeding has come to you at more than equal to 28 weeks. She is complaining of bleeding and they ask you the next step. Now please remember, because more than equal to 28 weeks पे जब भी bleeding होती है, it means it is a case of antepartum hemorrhage, and one of the most second most common cause of antepartum hemorrhage is placenta previa, and placenta previa ke patients mein per vaginal and per speculum examination is contraindicated. That is why in this case you will never say that I am going to do a per vaginal or a per speculum examination unless and until I am very sure that it is not a case of placenta previa. And since question में कुछ दिया ही नहीं है कि whether it is abruptio, whether it is placenta previa, I am not going to say that I will do a per vaginal examination or a per speculum examination, right? Now, whenever a patient comes to you with bleeding PV and they are asking you what is the next step, the logical next step becomes resuscitation of the patient. Simple answer that I am going to resuscitate the patient. चाहे वो antepartum hemorrhage की patient हो who's come to you with bleeding या postpartum hemorrhage की patient हो. First step whenever you have to manage a patient who's come to you with bleeding is you have to resuscitate her. And resuscitation के steps are the same. That means you have to put 2 large bore IV cannulas. And जब हम कहते हैं 2 large bore IV cannulas, what does that mean? Cannula number 14 or cannula number 16. Now you are going to tell me from your surgery knowledge that what is the color of cannula number 14 and what is the color of cannula number 16. You are going to tell me that. So tell me. What is the color of cannula number 14? Which colored cannula are you going to pick up? And what is the color of cannula number 16? Okay, orange is orange and grey. Right? Great. So, orange cannula and grey cannula I'm going to pick up. And I'm going to put 2 large bore IV cannulas, number 1. जब हम cannula लगाएंगे साथ के साथ I'm going to collect samples. I will collect sample for ABO-RH so that I know what is the blood group of this patient, and also for CBC, right? Then I am going to give her IV fluid. Which IV fluid? You have to give her crystalloids. You don't have to give colloids. And you have to catheterize your patient. You have to catheterize your patient and you have to give oxygen by mask. Right? So these are the general steps which you have to take whenever a patient comes to you with bleeding. Right? Now, itna karne ke baad, once I have resuscitated my patient, now I am going to see after initial resuscitation, I am going to check on two things. I am going to check कि इतना करने के बाद what are the vitals of the patient, right? कि क्या अब मेरे patient के vitals after giving her IV fluid have they become stable or not, right? And I am going to check fetal heart sounds, right? Now, if after doing initial resuscitation, in spite of giving her IV fluids, in spite of giving her oxygen by mask, if the vitals of the patient are unstable, itna initial resuscitation kar diya and still the vitals of my patient are unstable, or I am getting fetal distress. A fetal distress के लिए the scientific term which can be used is a non-reactive CTG. So, if after doing this much, I see कि अरे इतना करने के बाद भी my patient's vitals are not stable or there is fetal distress. Now, in this case, if this is happening, my management is going to be cesarean section. Wait, I have to move this so that you can. Okay, yes, better. Right. So my management is going to be cesarean section. Immediately cesarean section karo, irrespective of the diagnosis. I don't want to know ki whether this is a case of placenta previa or whether this is a case of abruptio. Right? Just hold on. My MacBook is about to discharge. Just hold on. Right. So I don't want to know कि ये placenta previa है कि abruptio है. If the vitals of the patient are unstable or if there is fetal distress, irrespective of the diagnosis, you have to do a cesarean section. But if after doing initial resuscitation, you see vitals of the patient have become stable and fetal heart sounds are normal. Right? Normal fetal heart sounds means fetal heart rate is between 110 to 160 beats per minute. Now I want to know whether my patient is having placenta previa or whether my patient is having abruptio. Right? So now what am I going to do in this case? Now in this case, I am going to do a transabdominal sonography, which is the screening test. Yesterday I was telling you that you have to do a transabdominal sonography as a screening test, right? So, if the vitals of your patient are stable and fetal heart sounds, दोनों ये चीजें होनी चाहिए, vitals stable होने चाहिए and fetal heart sounds should be normal, and they ask you what is the next step. Now the next step is not cesarean section, now the next step is transabdominal sonography, not TVS Rajshri beta. Screening test is transabdominal sonography. Right? Transabdominal sonography mein, if you are getting a low-lying placenta, it means you are dealing with placenta previa. And if you are getting placenta in upper segment, it means you are dealing with abruptio placenta. Now, once you come to know you are dealing with placenta previa, then you have to do TVS because TVS is the investigation of choice for placenta previa. Right? So initially हम TAS करते हैं, transabdominal sonography करते हैं, and transabdominal sonography में if I see that the placenta is in lower uterine segment, it is a case of placenta previa, then I have to go for TVS. Clear to all of you? Have you understood? If they ask you that a patient comes to you with bleeding PV at more than equal to 28 weeks and they ask you the next step, you are going to say next step is resuscitation. Resuscitation के बाद you have to look at the vitals of your patient. If vitals of your patient are unstable or if your there is fetal distress. In either of these two conditions, you have to go for immediate cesarean section irrespective of the diagnosis. Without trying to know कि I am dealing with placenta previa या abruptio, I will go for cesarean section, right? But if vitals of your patient are stable and fetal heart sounds are normal, now I want to know whether it is placenta previa or abruptio, and in that case I am going to do a transabdominal sonography. On transabdominal sonography, if it is a low-lying placenta, that means placenta previa, then my next step becomes TVS. Clear to all of you? Yes? Okay. Now comes case 2. Case 2 is, now just let me move this here. Okay. Now case 2 is that I have, if TVS, ma'am, what if during TVS placement, what ruptures, what have you written? Placenta ruptures. Arey Baba, listen. Suppose this is the internal os. So suppose this ring, what I'm this what I have made is the internal os. And suppose यहाँ पे uterus है, right? And ये नीचे vagina है. Are you understanding? So suppose this is the internal os. यहाँ पे ऊपर uterus and cervix है, या नीचे vagina है, right? Now in case of TVS में कभी भी जो हम विजाइनल प्रोब होते हैं, जो अल्ट्रासाउंड का प्रोब होता है, यू नेवर टेक इट इनसाइड द ऑस, यू ऑलवेज कीप इट इन द विजाइना, बिकॉज यू आर नॉट क्रॉसिंग द ऑस, देयर इज नो चांसेस कि प्लासेंटा विल गेट रप्चर्ड, राइट? प्लासेंटा की इंजरी का कोई मतलब ही नहीं बनता, बिकॉज यू नेवर क्रॉस द इंटरनल ऑस. जब आप पर विजाइनल एग्जामिनेशन करते हो, यू पुट योर फिंगर इनसाइड द ऑस, right? But when you do a TVS, the probe of the ultrasound, the TVS probe is kept inside the vagina. You don't cross the os, right? That is why per vaginal examination is contraindicated. TVS is the investigation of choice. And why TVS is the investigation of choice? Because it will tell you the exact distance between the placenta and the os, right? Okay. हाँ, right, beta, Dr. Hanif Ahmed. I am coming to case number 2. I was talking about कि आपको जो questions आते हैं, you get 2 types of questions. One is a question जहाँ पे they are not telling you anything. They are simply saying a patient has come to you with bleeding PV at more than equal to 28 weeks. Nothing else. Now comes a second case, right? Second case is that now you know that you are dealing with a case of placenta previa. Patient को पता है कि she has placenta previa, ultrasound में diagnosed case है placenta previa का, and such a patient comes to you with bleeding, right? This is what we are going to talk now. Now in this case again I am going to do initial resuscitation. जब भी patient bleeding के साथ आएगी, you have to resuscitate the patient. Now, after initial resuscitation, you have 2 options. One option is you say, "Kya nahi, I have to immediately terminate her pregnancy." Immediately terminate her pregnancy here means that I have to go do immediate cesarean section. So one line of action could be कि एक patient है, diagnosed case है placenta previa का, who has come to you with bleeding, आपने उसको resuscitate किया, initial resuscitation, and then you say कि फटाफट cesarean की तैयारी करो, right? So you tell your sisters, your junior residents, as a consultant, your senior resident, you tell them कि quickly go and prepare for cesarean section. Now if you are doing this, this is called as active management of placenta previa. It means you are managing the placenta previa actively, right? Or you can tell your junior residents, your associates that no, in this case, I think we have to continue her pregnancy. You don't have to prepare for cesarean section. So if you are continuing her pregnancy, that is called as expectant management. The other name for expectant management is conservative management, right? So have you understood? There can be 2 things as you can think about to manage placenta previa. Either you can say कि नहीं, immediately terminate करो pregnancy, go and prepare for cesarean section, or you can say no, let's continue her pregnancy. Number 1 case is active management. The second is called as expectant management. Now, expectant management या conservative management, it should be done without putting mother's life at risk. Without putting mother's life at risk, right? So, without putting mother's life at risk, if you can continue her pregnancy with the aim of attaining fetal lung maturity. Your aim is to let the lungs of the baby mature, right? So if your aim is that lungs of the baby should mature, you should continue expectant management between up till 36 to 37 weeks. So my line of thought is कि नहीं, patient की life risk पे नहीं रखेंगे, but if I can continue her pregnancy up till 36-37 weeks, that will be very good because the lungs of the baby will mature. So if you can do this, that is what is called as expectant management. Is this clear to all of you? Expectant management you are going to do only in one condition, that the mother's life should not be put at risk. Never are you going to put mother's life at risk in order to save the baby. Right? And I always tell this in my class also, ये कभी भी ऐसी सिचुएशन नहीं आती जैसी हिंदी मूवीज में आती है कि नर्स दौड़ी दौड़ी आ रही है एंड शी इज आस्किंग कि बताओ बताओ माँ को बचाएं कि बच्चे को बचाएं. अटेंडेंट नहीं डिसाइड करते ये कि माँ को बचाएं या बच्चे को बचाएं. As an obstetrician, it is your duty to save the life of the mother. Right? It is not the attendant who's going to tell you कि माँ को बचाएं या बच्चे को बचाएं. You have to save the life of the mother, and while saving the life of the mother, if you can save the life of the baby, well and good. But never are you going to put mother's life at risk in order to save the life of the baby. Is this clear to all of you? Yes? Okay. So now you are going to tell me in which situation are you going to do active management and in which situation you are going to do expectant management. So if vitals of the patient are unstable, so अगर patient के vitals unstable हैं, so obviously I am going to do a cesarean section and placenta को फटाफट से बाहर निकालेंगे and I am going to save the life of the mother, rather than I am going कि पेशेंट के वाइटल्स अनस्टेबल है एंड आई एम सेइंग नहीं नहीं हम तो प्रेगनेंसी कंटिन्यू करेंगे. नेवर एम आई गोइंग टू डू दैट, राइट? सो इफ वाइटल्स ऑफ द पेशेंट आर स्टेबल, then only you have to go for expectant management. Number 1. Number 2, see, why are you doing expectant management? You are doing expectant management so that you can save the baby, right? So that the lungs of the baby become mature without putting mother's life at risk. Now suppose एक patient है जिसके vitals stable हैं, but when I put a stethoscope, I see that there is fetal distress. So if there is fetal distress, जिस fetus के लिए हम expectant management कर रहे हैं, that fetus is in distress. So obviously I am going to go for active management. Expectant management should be done only if fetal heart sounds are normal. In other words, if CTG is reactive. Active management is done if CTG is non-reactive. Right? Third situation है कि आपकी जो patient आपके पास आई, patient is a known case of placenta previa. Her vitals are stable, right? Fetal heart sounds are normal, but patient को continuous bleeding हो रही है. Now, अगर patient is having continuous bleeding, then maybe just now her vitals are stable, but after some time her vitals are going to become unstable because she is having continuous bleeding. In other words, if bleeding is persistent, then you should go for active management. Expectant management should be done only if there is no active bleeding. So I'll write it here properly. If there is no active bleeding. No active bleeding. Right? Now, next situation. Now, if gestational age of the patient is 37 weeks, तो 37 weeks पे अगर किसी भी patient को placenta previa हो रहा है, no matter whether her vitals are stable, हो सकता है patient के vitals भी stable हो, fetal heart sounds भी normal हो, कोई bleeding ज़्यादा नहीं हो रही है, right? But gestational age is more than 37 weeks. अब gestational age अगर more than 37 weeks है, why do I want to continue her pregnancy when I know कि placenta previa is a recurrent condition? कभी भी नेक्स्ट टाइम ब्लीडिंग हो सकती है. The lungs of the baby are already mature, right? So I don't want to do expectant management if gestational age is more than equal to 37 weeks. Second thing, if gestational age is more than equal to 34 weeks and patient has had significant blood loss, then also you should go for active management. Expectant management is done at gestational age less than 34 weeks. Now, suppose there is a female who used to stay in a village, uska kabhi koi antenatal checkups nahi hue, right? This patient had an episode of bleeding, so the entire villagers, they took a truck, and now they have brought this patient to your hospital. While she was coming, her bleeding stopped, right? ये patient चल के आपके पास आती है, her vitals are absolutely stable. When you put a stethoscope, fetal heart sounds are absolutely normal. There is no active bleeding. You ask her that, do you have any ultrasound? What is your gestational age? She says, I don't have any ultrasound, but roughly I am 8th month pregnant. So you do a per abdominal examination and you find out that she's approximately 32 weeks pregnant. Now, सारी situations बन रही हैं कि you have to go for expectant management. But since she doesn't have any ultrasound, you want to first be sure of your diagnosis. So you tell her, I'm going to admit you, but please go get an ultrasound done. Now, when she gets an ultrasound done, on ultrasound, she has anencephaly or any anomaly of the fetus which is incompatible with life. So, if there is any anomaly which is incompatible with life, am I going to do expectant management? Why? किसके लिए? Right? So, in that case, I am going to go for active management. But suppose ये patient आपके पास ultrasound लेकर आई and either ultrasound was normal, या तो ultrasound normal है या उसमें कोई minor anomaly है. For example, there is an extra thumb in the baby. So then I'm going to go for expectant management. अब extra thumb की वजह से I'm not going to say कि नहीं let us do a cesarean section and terminate her pregnancy. No. Right? अगर extra thumb इतनी बड़ी problem होती तो we wouldn't have got Hrithik Roshan. Right? So, have you understood? When all these conditions are fulfilled, then you have to go for expectant management. Clear to all of you? When all these conditions are fulfilled. Now, active management का मतलब है you have to go for immediate cesarean section. There is no other mode of delivery. अब placenta previa का एक ही management है and that is cesarean section, right? Expectant management is called as McCafe and Johnson regime. McCafe and Johnson regime. इस पे question आता है. They ask you the name of the regime. For expectant management, you have to admit the patient because it is a case of recurrent bleeding in placenta previa. So you have to admit the patient. You have to tell her कि I am going to continue your pregnancy, but now you have to remain admitted with me. For lung maturity of the baby, you are going to give corticosteroid. Now, they ask you what corticosteroids are given for lung maturity. So, what corticosteroids are given? Dexamethasone. How many injections of dexamethasone? 4 injections, 6 mg each, 12 hours apart, right? And all these injections have to be given IM. Or you can give betamethasone. Betamethasone, you have to give 2 injections, 12 mg each, 24 hours apart. What is the only contraindication for giving corticosteroid? In which condition you don't give corticosteroid? There is only one condition, and that is chorioamnionitis. Chorioamnionitis, right? Now, if your patient is having preterm labor pains, then you will have to give tocolytics, right? And the tocolytic of choice is nifedipine. Then you will arrange for blood, because in case of placenta previa, there is recurrent bleeding. If your patient is a case of Rh negative pregnancy, you have to give injection anti-D. What is the dose of anti-D which you are going to give? So this you are going to give 300 micrograms. So you are going to give 300 micrograms of injection anti-D, right? And by doing this much, you are going to carry her pregnancy up till 36 to 37 weeks. Once she reaches 36 to 37 weeks, you are going to do a cesarean section, right? In placenta previa, you always have to do a cesarean section. Is that clear to all of you how we manage a case of placenta previa? Have you all understood? Yes. Just one very important thing which I want all of you to remember. In all patients of placenta previa, especially if they have history of previous cesarean section, right? So in all patients of placenta previa, especially if they have previous history of cesarean section, you should suspect placenta accreta. You should suspect कि हर patient जिसमें placenta previa है with previous history of cesarean section, you should keep the suspicion of placenta accreta in your mind, right? And placenta accreta के लिए what is the investigation of choice? Again, it is ultrasound, it is Doppler ultrasound. So जब भी एक पेशेंट आपके पास प्लासेंटा प्रेविया की आती है, especially if she has previous history of cesarean section, you have to tell the ultrasonologist कि केवल प्लासेंटा प्रेविया मत देखना, also switch on the Doppler and let me know कि कहीं प्लासेंटा accreta तो नहीं है, right? So this is something which you have to keep in mind. Great. So that ends today's session. Now, tell me, how is your preparation going on and why are you people getting so anxious? But there is one thing which I always want to tell all of you who have done your degrees from foreign medical universities. See, ultimately, you have to come to India, right? You have to get into this system. I really don't like to call someone as an Indian graduate and someone as a foreign medical graduate, right? This is a wrong demarcation to make. After all, you are our kids, right? So why should one child be called as Indian graduate and one child be called as foreign medical graduate? And foreign medical graduate should not be looked equal to Indian graduates, right? Why is that? You are the ones who have to prove everyone wrong. You are the ones who have to prove that you are equivalent to an Indian graduate and you have to enter into this system. And in order to enter into this system, you have to clear this exam. Otherwise, hamesha foreign medical graduate कहलाओगे. Somehow, I don't like this term foreign medical graduate because people don't look up to you. They look to you with disrespect when they see a foreign medical graduate, which is very wrong, and you have to prove them wrong. First of all, you have to say that I am no less than an Indian graduate, right? So you have to work hard and you have to enter into this system, and in order to enter into this system, this is the stepping stone. And ये journey यहाँ पे खत्म नहीं होगी. Just by clearing your MCI exam, you are not entering into the Indian medical system. You are just stepping into it. then you have to clear your PG exam, whether it is NEET or whether it is next. You have to clear that. And that is why whatever you are studying now, don't study as if I just have to clear my MCI exam. Read those topics in a proper manner, in a conceptual manner, so that when you are going to prepare for your NEET or next, you don't have to build your concepts again. At least अगर सारे subjects में ऐसा नहीं कर सकते, तो in some of the subjects read them properly. Right? So this motivation is something which is going to come from you inside. This motivation should come from within you, that I have to clear MCI and I'm not going to stop after just clearing my MCI exam. I am going to prepare for NEET or next and I'm going to clear that. I'm going to get a good rank and I am going to get interviewed by Sakshi ma'am. Right? So I promise all of you, the foreign medical graduates, the moment you become an Indian medical graduate and you clear your NEET or next, I will be taking up your story on Instagram or on YouTube. So see you on the other side. Ma'am, type नहीं, मिथिलेश पहले होता था कि टाइप 1 प्लासेंटा प्रेविया, टाइप 2 एंड उनके अलग अलग मैनेजमेंट होते थे. Now there is nothing like type 1 placenta previa, type 2 placenta previa. As I told you, there is a low-lying placenta and there is placenta previa, and management is always cesarean section. Right? Nothing, no other management. Always management of placenta previa is cesarean section. So all the best to all of you. Keep preparing hard. I love you all. And just in case you are falling short of motivation and you feel कि मेरे daily के targets complete नहीं हो रहे हैं, you can write your daily targets on Instagram story and you can tag me, and then once they are complete, let me know that ma'am, my targets for today are complete. Right? Great. See you all tomorrow. Tomorrow I'm going to discuss with you basics of abruptio placenta. Take care.